That was fantastic, Anita. So until we get the TriClip available in the U.S., what I learned is that we should take the green lights to go to Montreal. Okay, just follow the roads with the green lights.
Hold on, I was prepping my pictures.
No problem.
Are you going to have me go through pictures?
Okay, 1 second. So we're going to go to the live case. So Anita, come back up. Okay, and Neil Pham, Edwin Ho, Raj Makkar, Paul Sorajja. Becky, why don't you join us as well, if you'd like? Okay, we've got a MitraClip case. Love to get your insights. All right, so let's go to the cath lab.
I said yes.
You want me to show the valve area 3-5 or no?
No.
Okay, guys, can you hear us?
Yes. Can you see us?
We do see you. I can't see you on my monitor. If we can get that here, that would be great. But we see you on the big screen.
And you can hear us?
Yeah, we hear you fine, Anu.
Okay, good. Good. So myself, we have Dr. Tang on my left and Parasuram who is on the right, and Dr. Sharma is joining too. We can show the slides.
And
Case number 5. Eric? Oh yeah, on the echo is Lucy Safi, who's doing the TE with us, and anesthesia is Eric.
I think, look at the age, 92. Gregg, I think 90 was excluded in the court trial, about 90, right?
Right, 90. He would have been younger than 90,
Yes.
though, at the time of COAP, but you got him to...
Yeah, you could hear him without mic, right?
Yeah.
we hear you
The
fine.
mic on.
Yeah. So this is actually a very functional patient. Recurrent hospitalization, severe MR, and of course they'll show exactly the mechanism of it, and it's still good ejection fraction, and a little bit of aortic stenosis, but that's not the issue.
What's ACT?
TR.
Severe MR
Yeah,
actually.
MR is
Okay.
MR, so we can show the actually echo. That's the most important, where the money is. This was the old, and show the new one, please. Live, yeah.
Yes.
And comment, Lucy.
Okay.
So this patient,
Louder, yeah.
this patient has severe mitral regurgitation. So its etiology is an atrial functional regurgitation. So here you can see that the left atrium is severely dilated. She's leaking from mainly A2P2 and A1P1. She does have a chunk of calcium in her ones. And here when we're doing our bipomesural X-plane, you can see that right in the center, A2P2, she does have a jet there. And when we turn off color, the leaflet lengths are appropriate when measured. The posterior leaflet was around 11 millimeters in length. The anterior leaflet was about 16. On 3D, you can see that the valve does have some annular calcification on the posterior aspect and opens with appropriate valve area. Regurgitation, again, it's from the entire coaptation leaflet plane, but mainly from A2P2. Her transmitral gradient is only 1 at a heart rate of 50. And back to you guys.
How does the pulmonary vein flow look, Lucy? Do we know?
I can check that now. Yep.
Yeah, let's take a look at that, because that's, I think, important. We've seen patients even with 2+ MR, but the pulmonary vein flow actually normalized. So I think from a clinical standpoint, they would benefit beyond just looking at color.
Yeah, if there's reversal of the pulmonary vein systolic flow pattern, it's severe MR.
Right. And Gregg, our blood pressure map is 75, so it's very physiologic. So this patient is not hypotensive or hypertensive.
Okay. And I noticed her initials.
Done now transeptal. Sorry, go ahead.
I was saying her initials are MS. Not good initials for somebody entering into an MR case. But you guys will do great, I'm sure. So Becky, do you want to comment on the imaging? And how many cases have you seen also MitraClip done for atrial functional MR? We can talk about that because those patients were excluded from COAPT.
Yeah, I think we see a lot. I mean, we've just begun to really recognize it as its own entity. It ends up being a little more difficult to get down to ideal, to optimal results by MVAR criteria, because of the leaflet to annulus ratio, which Paul could probably speak more about. But if your leaflets aren't covering the annular area, then it becomes more difficult to affect a result along the entire coaptation zone. And so atrial functional tends to be one of the ones that are a little more difficult, actually.
Yeah. So we actually have it'll be out soon, a research letter that summarizes the results of 5 studies that compared the outcomes of the mitral clip in ventricular versus atrial functional MR. I don't know, maybe somebody on this panel probably reviewed it, but anyway, the results look very similar.
Are they? Yeah.
Not definitive, but they look pretty good. So, I mean, the mechanism is the same. The question is, can you get down there and can you reach the leaflets?
Can we show fluoro as well?
Yeah.
Okay, now we can go to the fluoro now.
Fluoro and echo combined, please. You don't need hemodynamics right now. So you can see.
Advancing the guide
Yeah.
slowly, yeah.
And
You have
keep the
echo.
echo in the bottom.
So do you have any,
Dynamics.
Yeah.
Anu, do you have any
So you can
different
see we-
considerations for atrial FMR? Are you trying to puncture the septum in a different place? Are you coming at it from a different angle at all?
Not really a same. We just go posterior
Yeah,
Nothing. Put a
just to
fluoro
get a
echo.
good height, yeah.
posterior
Atrial size is
and superior.
bigger. So, yeah. So,
Any tips, anyone on the panel?
Good. We're through.
So we through. So what you like to do is just a backward forward movement.
No.
Be gentle.
Switch them. This here.
I think the puncture is really relatively the same.
Yeah.
The only thing that might change me is sometimes if the coaptation planes are pointing posterior,
Guys
I might
across.
allow myself a little bit more of an anterior septal hugger,
Right.
or I just create one. But I try to pay attention to that as well. Yeah. But I think
Good
these
comment.
cases can be really challenging because there's not a whole lot of leaflet to work with here.
Right, that's
And
the
we
issue.
were commenting that there's a little bit of restriction in the leaflets.
I thought there was a little restriction too, actually. I was waiting for Becky to say
Yeah,
that.
they're a bit more like 3A than 3B.
Yeah.
Or atrial functional type 1. It's more of a, almost rheumatic appearing with some calcification, so.
It did look a little fibrotic and calcified, and that the posterior leaflet was a little restricted.
Yeah, a little bit of doming of that anterior leaflet, and so I was a little
Yeah.
concerned, and then obviously calcified and short posterior leaflet. So again,
Can we change
going to
it?
have some difficulties. What we like to do here is
Becky
flash on
and Paul,
3D
those
so
are
that we can
good
see if we're
points
at
and
the
interesting
commercial
points.
line.
The posterior leaflet Lucy measures are over 1 centimeter. So the question is a broad jet. So I think we need to expect our MR reduction will be realistic in a 92-year-old. We're not going to go to trivial MR here. I don't think that's realistic or no MR. We can aim for mild. That would be nice, 1+. But maybe with the broad jet, and you said, with the fibrotic leaflets, the gradient could be a potential concern, although it's 1 right now. So what would your clip selection be? We have our own biases, but we'd be interested to see what the panel says about the clip selection.
All right, why don't we go down, maybe start with Neil?
Yeah, oh, go ahead.
I would take NTW. It's, your risk of a gradient, but hopefully this is one and done.
Adam?
Yeah, I agree. We would probably do an NTW here.
I mean, we'd base the W or the regular NT on the valve area, so it looked like it was small, to tell you the
Right.
truth. So I don't know if Lucy had planimetered. We like to do the 3D planimetry of the mitral valve area, and then we need to know the patient's BSA, because we'll allow, it's about a 50% reduction in with the single device, typically. This is going to be maybe a little bit off to the commercial side, so a little bit more. And we can live with about a 1 or 1.1 centimeter per meter squared at the end of the case. So we don't necessarily use an absolute 4. We can go down to a 3.8 as a baseline if the patient's small.
It might
Yeah,
influence
that's a
me
great point. So
little bit
let's
more.
have Lucy comment on that in terms of we got a little bit of different valve areas based on our screening TE and our intraprocedural TE, and we can also maybe ask for what the BSA is on this patient.
BSA is 1.5.
So screening TE showed a mitral valve planimetered area of 4.2 square centimeters here on the table. Even with the cuff under her shoulder, we're getting a valve area of about 3.7, so a little bit on the smaller side. Her gradients, though, are low in both cases. Here, it's a mean transmitral gradient of only 1.
Yeah, and in a 92-year-old, she's not going to be running marathons. Probably relieving the severe MR is more important than even if she ends up with a little bit of a mitral valve gradient. So, in COAPT, we looked at this really, really carefully, and mitral valve gradients of 7 millimeters of mercury were really well tolerated in this patient population.
I think I would choose the
hands,
clip
3
also based on where you're going
hands.
to go. I didn't quite see where the piezo was, so if it's an atrial functional, I like the W going down the middle.
Yeah.
But if it's atrial functional, I would tend to think more of an NT if I'm going out to the sides. And that's just because there's a lot less leaflet to work with. And I think the leaflets lay flatter when you go down the middle. So I'd rather go down the middle if possible.
So we have 2 NTs, I think, and 2 NTWs. So Anita, you get to.
So I would say an NTW as well. The only other thing I would mention is, this one's not exactly the same, but oftentimes with atrial functional MR, the leaflets come up to the coaptation plane, and they're a little bit harder to grab, and there is a desire or an enthusiasm to use XT clips because of the longer arms make the grasping easier. The challenge, though, in cases particularly like this with some mitral annular calcification is the leaflets aren't normal. And those are the cases that may be at risk for leaflet tearing because you're trying to bring that annulus together, but it's somewhat fixed on one side because of the calcification, and the leaflet can tear.
Yeah, I would not try to bring this annulus together.
Exactly.
It's 92 years old. And the problem here is that if there's a tear, it's game over. There's no option for her.
In the atrial functionals also, the leaflets are very flat. And so you've got to remember that the XTs, it's 6 rows of frictional elements, and the top 2 don't hold on so well. It's only the bottom 4.
A lot of people do like to try to use the XTs, though. I've seen that.
So what did you guys choose? What clip configuration?
Well, so we initially wanted XTW. We're usually very aggressive about, annuloplasty and leaflet coaptation. We thought that we would be able to get a great result with an XTW one and done. But, based on the panel, and I do agree that the valve area is a little smaller than we thought. And Anita is absolutely right that XTW, this would be a quick case. Like for us, would be like a 5-minute case. NT will be a little bit more challenging potentially because it's shorter and there's a high riding A2. So, but we'll go NTW here and we'll see. Hopefully, we'll get a good result. And like I said, it's about setting expectations, right? So we're not, this patient is not running a marathon, and this patient, we're going to expect a, MR reduction, but will probably likely be down to 2+. Okay, the clip is coming out now. You see that here? Okay. And we are now ready to, let me just mag in here. M down, okay? So the M posterior, you can see that here very well. Lucy showing us. So sometimes it's nice to have a fluoroscopic landmark. So we look at the circumflex stance, MAC, and other anatomies to basically guide us to the depth. And you can see it's very posterior, so we're going to go anterior clock to bring it down to the valve. And we already go to the aerial projection to actually try to get to the view that will elongate. So you can see it's a little bit of an aorta hugger. You can see it's going posterior, so we automatically typically do a 90 degree or plus. And then we go anterior, and obviously now more medial, so we shift it more to central. So.
Okay, it looks okay. Open.
And then after that, we will typically do our jiggle as we just to take the tension off the system. Roughly take the parallax out on the fluoroscopy. You can see that you usually see the 2 clip arms on the bicomissural X-plane view, and then we're going to open the clip and check grippers. Okay, Lucy, we're going to grippers up, and we're going to open the clip.
Okay, ready?
Okay, a little bit stiff, okay? So we're going to drop pectoral is, okay, anterior, everyone agree?
Yeah.
Okay.
Yep.
Non-tactile is posterior, and then we go 3D on false. So in the meantime, I'm going to go. So the next step really, at least in our workflow, is to get the clip to the right orientation. So now we have to wait for 3D. There's a little bit of a aorta hugger here. You can see that despite puncturing pretty much mid fossa. So we might need to go a little bit more on the plus.
Go lateral.
And then go a little bit more lateral. So what do you think, Lucy, what does everyone think in terms of orientation?
I was just going to say, Gilbert, that you've got some pseudoprolapse anteriorly. So
yes,
I would
that's
try
right.
to get a little bit more correction of the aorta hugger, because otherwise the graph would be pretty asymmetric.
Yes.
Yeah.
Correct. We might have to go, because it's a shorter clip, to maybe even independent grasping in the extreme case. What does everyone think in terms of the orientation?
It looks fine, but Gilbert, I would just
Orientation
say,
looks
stay away from that chunk of calcium, just go right in the middle.
Yeah.
And I
Right.
would not do independent
Yeah,
grasping.
that's our plan is. We're
Independent
pretty
grasping is a
A2, P2
little
right
bit
now though,
risky,
right?
lady.
Dr. Kini, what do you think?
Yes, I think we are ready to
Yeah.
give you a look.
What do you guys think? We're pretty A2, P2 here. Lucy?
Yes, I agree. I think we're A2P2.
I mean,
All right, okay, so
I think
we're
we would
gonna,
try to
close
put a
the
little
clip.
more plus on and get rid of the aorta hugger, I'll be very honest. That's what we would do.
Yeah, so Becky, we already 180-degree plus. So we can
And you
try to
want it
do
the
that, but
midline.
remember, you're losing
And you
height,
want it the
right,
cup,
as you
right?
do that.
Just try
And
under,
we
try
can
under
go a little bit
straddling,
more.
and maybe you can
Here,
try
we
some
just did a
A-knob.
little bit more. So you can see we're almost on top of the valve now, right?
Under
That's the
straddle.
trade-off that,
Yeah.
And A-knob to gain height, and then you can correct your trajectory. Just take your time. This is not a
Yeah,
taboo.
I would correct, as Neil said. So
yeah,
you
okay.
end up coming back a little posterior and then use the
So
A.
we got now A. Yeah, we did all the A. So we did a little bit of A, like you said. It goes lateral. And then we'll go a little bit on A to correct that. Yeah. And then we'll move the stabilizer a little bit more.
Medial,
Yeah, medium, central.
central, yeah.
Okay.
I think I have to go a little.
So I think it got a little bit better. Yeah.
This is something
Yeah,
in the
I think it
future that
looks
should be
better now.
very easy for AI to figure
Yeah,
out.
definitely better.
Put the clip exactly where you want it to go, and AI will figure out
Yeah.
the three-dimensional turns
Well,
and the order to make,
yeah.
and do it.
I agree with you. Except we wish it were that easy, and then you have everyone in the world be able to do this very well, and that would be ideal. So we put us floral safe here because we threw some of the work from Anita and Jason's M-tier textbook from Sky. We actually want to make sure we go in and make sure it doesn't have a medial lateral dive, and make sure that it stays in the parallels.
2D?
Okay, so now you can see that it went in, right? I think it looks pretty good here. It went a little bit more medial, right? You saw
It
that?
dove medially.
Which is
Yeah, it
interesting
did
because,
move a little
with A,
medially.
you often have
So
a
let's go back now here. Okay, so I think it looks pretty good, guys. What do you guys think? Yeah, it's a little deep, so you ready? Okay, so I think we're going to open, and you can come up and grasp.
Take the 2D, 3D out.
Yeah.
Why are they showing so many?
Okay, let's just 2D.
Just
Lucy,
2D.
Bicom explain, please.
Yeah.
Okay, yeah.
Okay, so I'm going to open the clip now.
Yeah,
It's a little rotated
that
already.
looks pretty good.
So, yeah.
Everybody
Okay.
happy with that?
Can you put color?
Getting silent nods.
Put color on
Yeah,
to
put
see
the-
if you're close to the jet.
Yeah, we're on the jet. We know where the color is, Neil. So
Yeah,
we're just
if
going to
you
try
flash
to
it on
grab
real
right in
quick.
the middle. So
We always just flash it on real quick.
posterior is on.
Under,
Yeah.
yeah.
I,
Going way in.
Yeah.
I think it'd be nice to
Going in?
see like a dedicated grasping view. That's how we would do at this point. We'd go to the LVOT and just mag up. Sometimes you can see the leaflets curling or interact with the gripper in ways that you may not want to look
There you
at.
go.
There you go, because you see, because you're interacting there posteriorly, yeah.
Yeah, that's right. Now it's, yeah.
Posterior.
That's good. Close.
Okay.
Yeah, this is where that aorta hugger hurts. Yeah, see that anterior leaflet override, it just makes the asymmetric grasp
Yeah.
more challenging.
I agree with you.
So maybe repeat.
That's
your
why we like,
3D.
hey,
Let's do independent. Let's drop the posterior.
yeah. So let's go anterior first.
On anterior?
Yeah.
Gilbert, maybe consider repeating 3D. It may have rotated a bit.
Yeah, one floral has not, so I'm going to drop, which is anterior, just tactile. Okay. Okay. Go posterior now.
Yeah, posterior.
Yep. Go posterior.
Good.
Posterior.
Okay.
All the way. All the way. More. Good.
There you go.
Okay. Drop.
One posterior, please.
On the
Okay.
side.
Okay. We drop. Lock. Looks pretty good. We lock.
Close.
Attention.
Go posterior, please.
Yeah, I am.
Okay.
Good. We might have to optimize posterior. I think we don't have enough. Yeah. I will optimize posterior here.
You want to see color first?
We can see color, but we know that there's not that long leaflet, so I don't think there's any point.
Show us the color.
Yep, color.
Yeah.
Exclude the chat.
Okay. So Lucy, we're gonna open and optimize posterior. Color off.
Yeah, on your
clip
3D
is also
color, on the
rotated.
3D color on FOSS that you showed at the baseline, the jet seemed to be ever so
Yeah.
slightly lateral to midline, which this is now
Yeah.
showing us to be true. So that's why we like to put
Yeah.
the color on before we drop the grippers, because we can always correct.
Then close on color.
Okay, more posterior. Okay, Lucy, we're gonna optimize posterior.
I'm ready.
Sometimes.
Go over. Yeah. Okay. So actually, it looks pretty good. And Teer was good for this one.
Very posterior.
Mm-hmm.
Dropping.
Yeah, go. Good.
Posterior leaflet looks really good here.
Yeah.
Take what you get now.
Yeah.
And evaluate. And go anterior.
One thing that we also started looking at, I'm sure you probably noticed as well too, is that as we close, we also look at the bias of the device. So if the
Yeah, I
device
know.
moves
You can
a little
see that
bit
we're wearing
anterior,
posterior
then
guide
you know
talk
you
already.
have, you've got asymmetry in the grass, or you may have lost some posterior. So we look at the swing as we close too. So here you can tell
Right.
that you're not as close to the posterior annulus as you were before you started to close. So that, and it's,
Right.
it may be because the anterior leaflet's really thick and you have more anterior leaflet, or maybe
Yes.
because you lose posterior leaflet, but you just have to be prepared for that. So.
Correct. That's right. That's why we optimize. It looks like we might have stretched, we lost a bit. We can look at color now and see. So we got that rid of the central jet. Looks like that's the lateral jet, as you guys
Yeah.
predicted. So I'm curious about the gradient actually, because that was the concern, right? Initial concern of the group.
Yeah, and the leaflets are thick, so you're going to lose a lot of valve area. I
That's
would
right.
move
So
it
let's
over.
have Lucy take a
I
look
would do
at the gradient
I would
first.
use this device, move it lateral.
Yeah, because
Yeah.
I think you would need a second clip to treat that residual jet, and you'd rather
Yeah,
not do
but
that.
we're not. I don't think this is a two-clip case.
Right,
I think
exactly.
everyone would agree that this is a one-clip case. Question is
Exactly.
whether we can optimize the location to do a little bit, reduce a little bit more MR. But the trade-off will be basically you can see already 6. So you're gonna gain some jet medial to the clip at the expense of less lateral. And you can see it was not a straightforward grass that you have to do independent because it's a shorter clip.
Well, it's probably worth one effort to try to
Yeah.
go a little lateral.
Yeah, if you're going to stick with XTW.
I mean, I think
you should move it
let's take a
lateral.
look whether we can grasp that, because remember, I think you guys are, and rightfully so, and Lucy mentioned that about the Mac, right? You see that there? So this is the clip, and if you go lateral to that, Lucy will show you. That's what we're fighting against. What do you guys think in terms of that posterior leaflet? It doesn't look very healthy to me, and it's a little echogenic.
Lucy, they're saying, should we go lateral or leave it? Go
Paul,
lateral.
Becky, Neil, Anita, what do you guys think? What would you do here?
I would either
You got a
move this-
grasp.
move this lateral or take it out and put in
You basically
NTW.
got rid of the jet, at least in central, but now obviously you have
So our
lateral
algorithm
jet.
is first to know what the EROA was at baseline, and then our
Mm-hmm.
goal is to get the EROA by 3D down to 20 or less We've shown Denizen maybe in the audience here. There he is. And he did that study for us at Columbia, and it was associated with with long-term outcomes. It was multiple, outcomes. It was a combined primary outcome. But Denizen showed that 20 millimeters squared, which is the cutoff from mild, is indeed prognostically important. So we don't leave 20. We try not to leave 20. Sorry, sometimes we have to leave 20.
Yeah.
It's interesting, so in the 3D, it looks like your clip may be rotated a little counterclock, so maybe a little pinwheeling, and that can be really difficult in somebody with not a lot of leaflet to work with, like HOFMR, because you just don't have much leaflet to bring the coaptation planes together. And the other thing that I was just noticing is that the LA pressure looks like it's gone up. I think it was around 18 or 20.
What's the map now? Yeah, the map also went up. So the map, interestingly, went from 75 to 88.
Yeah. So, it just I think LA pressure is relatively insensitive, but when it does go up, and it's relatively specific for things getting worse, not getting better. And so I would try to move this clip lateral.
Okay.
That seems to be the consensus.
Okay. All right, so we will raise the grippers, unlock,
Open.
when open. Okay, so obviously it's a lot of tension in the system. So I think what this plumber will do, we will have 3D and look at the orientation again.
So maybe
I think we're
just
actually caught in the
Posterior.
just a
posterior.
question for you, Gilbert. Since you went in, you dove a little bit medial as you went in. So the question becomes, what's the
let's
best
caught
way
in
to go
medial.
lateral? Do you try to move the stabilizer, or are you better to come out and then reposition? Because my concern is you may not move. I'm not sure how well you're going to move.
Right, exactly. So
I turned on the drips.
let's see what that looks like. Yeah.
Counter.
It's interesting how easily caught it is despite being annular dilatation. So I think we look at, you can see very, very clogged, right? So we're going back to a non-parallax view, and we're going to potentially.
So Anita, if you pulled out and went back in, what different
There you go.
vector?
So we're a little bit lateral now. What do you guys think?
More.
And we purposely clog a little bit to like 130, 630 kind of orientation.
I think that perpendicularity is better. I like that more.
You like perpendicular, just a 12.6?
No, I like this 1230, 630. I think that's a little bit better because you're touch lateral. And again, you don't have a whole lot of tissue to work with, so getting it as perpendicular as possible to wherever you are in the valve is really important.
I know, yeah. So how about now? So I think we made some changes.
So can I ask how
Okay,
you
so let's
moved
go to-
laterally? Did you just move the stabilizer, or you took M off the device?
Yeah, we did. Yeah, we did. We felt that the shaft looks pretty straight. I don't think we need to release more M. So, Lucy, what do you think?
I like this. I think orientation.
Okay, then let's go 2D. We'll have to see if we can,
You want 2D?
yeah.
I think orient better, no?
Wait, now I think it is.
12 and 6. 12 and
Yeah.
Say it again?
Are we lateral enough?
On 2D it was, but we can certainly go a little bit more. Here.
You could also rotate your orthogonal view maybe a little bit more to get the clip arms a little better aligned. I don't know.
Do it on your way.
So,
Actually, LA pressure went up a great bit.
okay, so we're going to try to get anterior first. So, I think we're still above, actually. Now we're below. It's harder to grasp here, so we'll see. Okay.
do what he normally does.
No, that's what I'm saying.
Okay, I think we got anterior. No, it's very restricted. You see that there, right? So
Okay, that may
Yep.
it's a short
Tight
tip.
down.
Yep.
Yeah. That's better.
Yep. Mm-hmm.
Ready?
Go. Good.
Here.
Okay, the challenging with atrial SMR is how do you get the posterior that you know with the independent. Not my favorite thing to do, because when you go posterior, you have to hook it. And sometimes some people even do intentional aorta hugger.
Go down.
There we go, getting there.
It's buckled.
Yeah. Okay. Yeah.
There you go. It's just the guide talk is going to be challenging because of the anterior leaflet, as you said, is pulling onto the posterior leaflet, onto the device, and you actually can feel it on the delivery system.
Okay.
Okay. Yeah. No, don't drop yet.
Drop it down.
No, yeah, I would go more. Are you drop already? Not yet. Okay, ready?
Yeah.
Okay, good. Okay. Go. Good. Okay.
We'll be ready in 2.
All right.
For the panel, do you think having a spacer helps in a case like this?
Yep. Advance. Lock.
Yeah.
I mean, you could, a Pascal. Obviously, this is functional, so we don't have indication right now to use
Right.
Pascal in the United States.
Looks like it's
But,
back, maybe more, it's not as lateral.
That was supposed to
Okay,
be one of
let's
the
see.
advantages, right?
Yeah,
When there wasn't a
correct.
lot of tissue to grasp.
But you'd want to use the P10, and you'd never be able to get underneath the free edge because it's too wide. You'd not get through the quartz. You'd have to use.
Okay, let's see what you guys think. Color?
Looks good.
Better?
Much better.
better.
Oh, that's a lot.
Better.
That's better.
Not perfect, but better.
That's probably 2+.
We knew that, right, Greg, when we come in?
Absolutely,
We get this to 1+.
absolutely.
So,
This is a tough case. 2+ in her would be a win.
yeah, and you can see there's not much leaflet to grasp if you want to
Right,
go more lateral. So
right.
I
And
would
like you
say
said,
this
you
is a
can't do a
win.
second, you can't do a second clip in this case.
No, we know this is a one-clip case.
Get a gradient, Lucy.
Yes.
LA pressure looks much better.
Yeah, again, the map is high. The map is 82. Systolic is 140. Can we improve the blood pressure control a little bit for him, please?
Make it like 120. Systolic, yeah.
Let them go for another lecture, I guess.
Yeah, so 6. That's acceptable. Especially remember her systolic pressure right now is 140, so we're not like hypotensive, and the gradient is 6, so we worry about stenosis per se. So I think, what do you guys think about going ahead and deploy? Go. I don't think we can get.
I don't know that you're going to get much
so-
better than that. I think 6 millimeter gradient's, I think, acceptable.
I guess what we were just discussing is whether or not you want to move just a touch more lateral. The one thing I
Yeah,
would say is
I know,
that
and I
the
don't-
gradient
yeah.
is only 6, but your heart rate's 55 or so, or it was
Yeah.
60. So we know it'll be 7 or 8 on tomorrow's transthoracic,
Yeah.
and so it's just one of those things that makes it a little bit more challenging. The other thing, sometimes what we've done in these situations with small valve areas is you can actually open the arms to 30, and you can leave it at 30 technically, and that's
Right.
perfectly fine
Yeah, but
too.
you trade the MR.
Yeah,
against the
so
MR,
what we do
right?
is we do it
Yeah,
on
we
color.
agree with that, so.
We do it on color, and as long as the MR doesn't get worse when you open to 30, then I'd rather
Right.
take the lower gradient with the same MR result.
And what's
Yeah.
what's the left
But you
atrial pressure
you see
done?
smoke in the atrium, so actually,
Gilbert,
yeah, I think we're going to go with
accept
this. Also 92-year, we don't want the general anesthesia time. Our average clip time here is like 5 minutes for one, and 5 to 10 minutes for one, and 20-30 for the other. So we don't want to have a long procedure time either. So
Yeah, Gilbert,
I
the
just-
enemy of good is perfection. This is a 92-year-old lady who's done independent grasping twice. I would take it.
I know.
I would deploy and run.
That's what I would say. I was going to say, if it's a 65-year-old primary MR patient, that's a little bit different.
I'd just like to see
Okay,
that left atrial pressure come down a
The clip did
little
not
bit.
open up. right? You agree with that? We go LAO to TC, we increase the flush.
What's the next case?
I'd be interested to hear what everyone else's experience is as far as release of, and increase in
Sometimes the gradient come down after the release,
I mean, do you have
actually.
methods to
Okay,
reduce the
flossing?
tension on the device? And does that always work?
Are you talking about like advancing?
Advancing a little?
Yeah. Sometimes you're pulling on it more, yeah. And here you can actually,
Yeah,
if you
we
look at, if
did,
you look at
we
the
did that already.
CDS.
We gave back the tension, Becky,
Yeah.
already. We
If you look at the
advanced it down.
CDS,
What
there's
we
tension
say
on
is
the
that we
CDS here.
do
You can
it
see.
below the coaptation line, I mean the annular. You don't want to pull the valve up. Okay, we're going to check again. Block line is out already. Everyone agree it's not
Opening.
It's not opening. We go neutral, go REO. So we like to deploy in this, kind of parallax free view to make sure we can see the pin properly, can see very good, a lot of posterior guide torque already. So we expose the groove. So we'll do 9 turns, 1 extra for good luck. So, and I actually advanced, go to anterior guide torque a little bit more before we put a pin, because you can actually get the pin out, and we do this very slow. You see that?
There it is.
Very stable. Okay, good. All right. So a lot of knobs, right? Remember, you also have to do a knob to gain, and it looks better than.
That
than
does
after
look
release.
better.
So.
Let's get the blood pressure.
Yeah, it's like,
Mild, moderate, maybe I would say, Becky, what do you say?
yeah.
You're the imager and
Yeah,
is
no,
Edwin
I think this
Edwin's
looks
very
good.
quiet.
What,
good.
1, 2
there?
plus, 1 to 2 plus?
Yeah, looks pretty good actually.
Okay, flush, please.
1.5.
Good.
That's
Okay.
better. What's the left atrial pressure?
Well, we're getting it now.
Are we back to?
Around, actually, about 16, 20. It's got a little improvement. So, yeah. And maps around 70 now. So,
And we started at 40 almost.
yeah. Okay, so
Okay.
we're going to remove the guy now. So we could go back to the right atrium. And I think, we basically finishing up here.
But echo is all done?
Yes,
Good?
we are done.
Okay.
Everybody happy?
Yes.
Right?
Yep.
Greg,
That's
I
great.
think we should go back to lecture till we get the case ready here.
That's terrific. That was a really challenging case, and you did it in a very thoughtful, careful manner, and I think you got pretty much as good a result as you're going to get in this kind of lady. I think she's going to feel a lot better. So
Yeah,
great.
And to Neil's point, you remember a 92-year-old tissue, and we see them in the operating room, that if you keep grasping, you end up actually causing leaflet tear and damage. I know we want to have a more MR reduction, maybe less gradient, going more lateral. I just find that with the shorter tip in this situation, the leaflet tips are thick. So it's not that easy to get in there. You saw even we struggle a little bit to get the posterior leaflet, to get in there, to get the insertion, and also with the anterior leaflet as well. So I think this is a win for the patient without hurting the patient.
Could we see pulmonary veins? Because that could be a real win.
Yeah, let's do that. So yeah, sorry. So Lucy, let's show that.
Did we see it at baseline?
For
I don't remember. Did we see the pulmonary veins?
Can you on the main screen now?
Not
Can you
reversed.
go on the main screen? No need for fluoro now.
Lucy, what was the veins that before?
So remember, she's atrial functional, very large left atrium reservoir. So they were only blunted.
Okay.
I don't
But
know.
the good thing, we actually see smoke.
Yeah.
But yep. So
This
I'll
is-
check off
This is improved, I
the
think.
left upper.
Yeah.
Yes, it
Yeah.
definitely did.
If we see the other one, let's see.
And one of the frustrating things is, I would be interested to hear what the panel says.
Oh, that's a
with
win.
atrial
That's a
secondary
win.
MR.
That's a
If you
systolic
don't fix
dominant.
the
and,
AFib, it's very
yeah,
difficult.
two
It's very
studies out there
frustrating,
showing that any change at all that you exhibit in the pulmonary veins will have a good 1-year reduction. If you have systolic dominance, it's a good 2-year reduction. Outcome
Yeah.
as far as
And
mortality.
that's definitely
so this is very
systolic
good.
dominance. So you made Becky
that's
happy,
what
so
we see
you
now.
made the rest of us happy too.
I was just going to chime in for the cat
Okay.
person. The LA pressure is almost normal. And then that also, we have a study
Okay.
that shows that that's very prognostic too. So despite whatever MR there is.
All right.
All right, Greg,
All right.
fantastic. If you can just continue the lecture series. We thank you for the great input and beautiful case. Thank you.
Thank
All
you,
right,
guys.
fantastic.
It was very helpful.